What I'd like to do, and I've done it before, I can see a lot of familiar faces out there, is first give an introduction to how I like to do this, because that'll, I think, short-circuit a lot of the discussion for all the rest of the talks. So as Rick mentioned, I've done this for many, many years, and no matter how we try to focus like a laser on a particular issue, there's still always way too many abstracts to cover. I mean, when you look at the volume of the medical literature, it's just astounding how much stuff is out there. So what I like to do is take the clinical question that we're asking, and if the literature in it gives a straightforward answer, I'll just give you the answer. I don't feel like I need to torture you with statistics and all that kind of stuff. The trouble is that for many of these, it's not quite so clear-cut with these. There are methodology issues that actually really do matter. I think the biggest reason you have to look at is, why is there so much medical literature? Thousands and thousands and thousands of articles out there, whether it's emergency medicine or other stuff. Why are people writing so many papers? Well, first of all, publish or perish. I mean, if you want to advance academically, that's fine. You gotta get out there and write stuff and contribute and all that. That's fine, depending upon why it is you're writing it. I think most people who write a study or publish a paper, do whatever, they believe they know an answer to something. They believe they know something. So when they design the study or their data or how they analyze it, in a charitable way, you would say they optimally expose the experimental variable. They make the study show what it is they want to bring out. And I mean that in a good way a lot of times. So if you want to do a study on mortality, you have to give a fair amount of time to it, so there's, so that actual variable can come out. Or you need a high-risk group of people where mortality is going to be high. If you study mortality in skiers at Whistler, it's going to be a long time before you get a lot of data because mortality is so low. So when you design the study, you need to do that. On the other hand, the evil side of that is you can game that to make it come out the way you want. There's a study in here, I'm going to do the migraine talk in a couple of days, where somebody wants to prove that I think it may be a non-steroidal or some other medicine is as good as Demerol for migraine headache. So they give you, I think it was DHE, by the way. I think they give you 5 milligrams of DHE or 25 milligrams of Demerol. Of course it'll be as good, because you're given a tiny little dose of Demerol. So you can game the study, and when I see a study that looks like it's gamed, my antennae go up. Somebody's trying to spin this, The other time my antennae go up is when there's data that's there that you're not being shown. And that would be even more convincing if it showed what they wanted it to show. And I know if they have, that data and they don't show it to you, I'm skeptical on that kind of stuff. I'll point out the red flags in a lot of these things, because for the most part, it's not so much what I think of what the study shows or what the faculty thinks of what the study shows, or even what you think the study shows. It's really, can you apply that study to your clinical practice? So when Billy Mallon, I noticed in here on the seizure chapter, he writes about, the many causes for seizures, neurocysticercosis. And I think, sometimes where I practice, weeks go by that I don't see neurocysticercosis in the ER. And he practices at LA County. That's a big issue for them there. I have to read up on it every time I have to give the lecture because, I never see that stuff. So a part of this course is really about how to read and interpret the medical literature so that you can take an article and see, does it apply to where I practice and what it is I do? So that's why I do cover some of the methodology stuff, because little things really do matter. And reading the fine print and actually having the study sometimes really does matter. I think the best way to look at these, or any study that you're going to look at to see what it can do to your practice, is ask the clinical question, what's my clinical question here, and then design in your head, how would I do that study? The controls would be this, and how long I'd study it for, and all that kind of stuff, and then see how the study that you're looking at compares to that, because sometimes it's startling how it's not done that way. The other thing I'm going to mention a lot of times, I think we really need to internalize this idea of association doesn't prove cause and effect. I think we all know that inherently. If we had to take a test and it says, does a really, really strong association prove cause and effect, you would all know to check the box that says no. We don't believe that. The ultimate example I always give for those of you who have heard it, I can tell you about a drug, and it's associated with incredibly high mortality, amputation, morbidity, long hospitalization, all these terrible things. And it's insulin. Does that mean it's a bad drug? No, it's the people who need it have an underlying medical problem. So the obvious answer there is no, of course, this is not a cause and effect that insulin is causing amputations or insulin is causing heart attacks. It's the underlying disease that's doing it. So you understand it at that level. Always think of that example when somebody says it's associated with, okay, because that doesn't necessarily mean cause and effect. Well, that's enough of a diversion. Let's start on the pneumonia update. This whole chapter, and I actually have written it, is sort of what I call a meat and potatoes ER kind of thing. There's some good sort of basic meat and potatoes things that every day we see people with lots of respiratory symptoms, and sorting out the pneumonia issues is a practical issue for us here. So first of all, for all those people who come in with a cough, is there some way we can figure out who's got pneumonia? It's a legitimate question. The first study here looks at, how about just looking at, do they have abnormal vital signs? Tachycardia, elevated respiratory rate, hypoxia on blood gas. And so the more of those you had, the more likely you were to have a pneumonia. So that makes sense. But you couldn't add up a given number of them and say, oh, therefore, you have pressure less than 90 and a big respiratory rate, therefore you have pneumonia. They were all good common sense, but there's no take-home message that says you can actually do that to use it better than physical exam. The second one also is another study like this. They like to look at, can you use C-reactive protein to diagnose in patients with cough who's got a pneumonia and who doesn't? This is a classic study for a non-specific marker. As far as I can tell, C-reactive protein is good for everything. Okay, if I told you, oh, her C-reactive protein's 60, what's the diagnosis? Well, could it be appendicitis? Could it be pneumonia? Could it be meningitis? It is too non-specific. But if you then narrow it down, patients with cough, how good is it for that? Well, this is a classic study where people want to kind of make it look good. They took 400-some people here, and they threw out 128 because they never got a chest x-ray on them. So they assumed they didn't have pneumonia unless they got treated with antibiotics. Has anybody here ever treated somebody with a cough with antibiotics that might not have had pneumonia? Of course. So right off, you say, that part's not good. Then what they did is they looked at the C-reactive protein, and they did this retrospective look. They said, well, here are all the people with pneumonia, and their average value is, I don't know, like 60. And here's the average value of those that didn't have pneumonia, and theirs was 6 or something like that. So if we do a cutoff of 40, below that, no pneumonia. Above that, in our case, pneumonia 70, 80% of the time. First of all, 70% is not all that great for sensitivity. I mean, is it just better than listening for rails or these other vital sign stuff? So even if you did a retrospective cutoff, and then the terminology here is called data dredging, where you go back and do that. So that means that worked for this group of people under this study. So then the question becomes, how about your group of people? And we don't know what that means because we haven't done the proper study. They even properly conclude that if validated, it might be useful. I don't think it's caught on, so I think we can kind of do that. Whenever you look at a pneumonia study, the whole concept of the gold standard comes up. And we're going to go over this time and time again in every part of this course. What's the gold standard for the diagnosis? For some things, the gold standard it can be pretty well defined. Appendicitis. They went in and took out the appendix, and it was inflamed at the pathology lab. Even that, you talk to the surgeons, they kind of beat up the appendix a little bit before they take it out, and there's a little inflammation in it. So even that gold standard may not be quite so good. The gold standard for pancreatitis is all over the map. Clearly, it can't be your amylase. We know that's non-specific. Can it be there on CT? How about on ultrasound? If you use autopsy, you'll get the severe ones, but you won't get the others. So the gold standard concept goes through all of these, and the gold standard for pneumonia typically is the chest x-ray. Well, we all know chest x-rays can have other findings that look like pneumonia. Pulmonary infarction can look like pneumonia. Actually, my favorite study is not one done in here. It was pediatric pneumonia by pediatric radiologists at the Mayo Clinic. We all bow slightly when we say the Mayo Clinic. So what they did is they took a bunch of little kids' chest x-rays, and they said to the radiologist, blinded, do they have pneumonia? And some said, yes, no, left lower lobe, right lower lobe. And then they took the same radiologist 3 months later, showed him the same x-rays. One of the beauty of radiology is they can show you the image time and time again, and you forget which ones. And half of the time, they disagreed with their initial reading. And even when they agreed with the initial reading, they said it was someplace else. Like, oh, sorry, it's not on the right, it's now on the left. So it is really just an opinion most of the time in terms of is there pneumonia there, especially with kids, where we all know those are iffy readings. So this said the same thing. Number 3 said, do the ER docs and the radiologists agree? Half the time they don't. I think obviously as ER docs, we have that pre-test probability issue going in. We know they look sick and they're coughing and maybe they have rales. And so when we see a little bit of a density there in the right lower lobe and on the lateral, maybe that's the spine overlying it, but maybe it's something there. We say, pneumonia there. And the radiologists don't have that. So that was one. I think it's just worthwhile that we know that we won't agree all the time. The one I like, though, is this best one. This is University of Alberta in Canada. Anybody here from there? My conclusion was they have real smart ER docs there. They took patients admitted with a diagnosis of pneumonia who had a negative chest x-ray. And within 72 hours, 2/3 had the radiographic diagnosis of pneumonia. So one of two things. It was early before you saw the radiologic changes. The ER physicians were sort of reading the patient and knowing that they were sick enough with this that they needed to be admitted. Obviously, they're pretty sick with a negative chest x-ray to get admitted for pneumonia so that they were real smart, or it just doesn't show up for a while. So I think this is actually a good one. 2/3 of the patient with clinically suspected community-acquired pneumonia can have a negative reading. Now, either this or they have some radiologists who aren't willing to call, minor changes, but whatever. How about the impact of blood cultures on the management of community-acquired pneumonia? How many here get blood cultures? If, say, they're going to the ICU, where we've got this, these standards that we had where you had to get a blood culture on them if you admitted them with a community-acquired pneumonia was the worst thing in the world. It's finally gotten to be much more rational. I can quickly go through what all these studies show. They show what every other study shows. Blood cultures in community-acquired pneumonia aren't useful. And they're not useful because in all the studies here, the false positives either just about equaled the true positives or they exceeded the true positives. So that you get a blood culture and it winds up being a skin contaminant or something like that. The cost of chasing down a false positive blood culture is hundreds and thousands of dollars for something that isn't even true. So that's the number one item. Nobody finds it very useful. Even when they have positive blood cultures, it doesn't impact their choice of antibiotics because most people got the empirical antibiotics that were going to work anyway. Even when patients were bacteremic with the pneumonia, it didn't change treatment, and those people did no worse than those who weren't bacteremic. We would think it made common sense that if you're bacteremic with a pneumonia, you must be more sick. Well, we all know you clear bacteremia pretty fast. So they just happened to catch it, and they gave them the right antibiotics, and no bad things happened. At 7, I thought was an interesting one here. It took 5 days to get the report for the blood cultures. So, you're either dead or better. At that point in time, it's really sort of too late. Unless, if you have a very strange and unusual immunocompromised patient, foreign travel, all kinds of complicated stuff, maybe it's useful there, but in general, it's not. I think number 8 concluded, you'd need to have 125 patients with pneumonia to find one patient with a resistant infection, resistant to the usual common antibiotics. And most times, the antibiotics get changed anyway because the clinical course is not going well. And somebody just adds something else thinking maybe they've got a resistant organism. So it doesn't really help. 10 had the false positives were equal to the true positives. How about gram stain? How many here are old enough to have remembered when you had to collect sputum from your patients and go down and look under the microscope and trying to decide what's a white cell and all that kind of stuff? I remember doing that. That's classic infectious disease where you would have to collect the specimen of interest, whether it was pus or sputum or stool or urine or something, look at it under the microscope, and those skills, I think, deteriorate very quickly when you don't do it all the time. But I mean, it's classic infectious disease. Get the sputum, look at it, and if it's loaded with the right kind of organism, aha, that's pneumococcal and rusty sputum, and that's other stuff. So they really looked here and said, is this really useful? The answer is no. Of course it's no. They successfully got sputum specimen from only half the patients. So most of the time when you ask for sputum, what do you get? Saliva, right? And only half of those specimens was considered of good quality, and only half of those had something on them at a predominant morphotype. So, and then those patients, the only things you found were gram-positive diplococcii, and they all got treated as if that's what they had anyway. So that's why it's really not useful. Maybe in the ventilator-acquired, 2 weeks in the hospital kind of case, that's when infectious disease finds something that may be useful there. I don't know whether they do or they don't. But for community-acquired pneumonia, it certainly doesn't matter. The Pneumonia Severity Index. How many here even know that term? How many here use it and calculate it and do things with it?
Only to sell an admission to the hospitalist when they don't really want to instead of...
Excellent. They're PSI, they're 4. They're level 4. They're level 4, they need to come in. And then what you realize is they don't know what that means, and they're too embarrassed. Right, they're too embarrassed to admit they don't know what a PSI of 4 means, so they say, oh, whatever you think, kind of stuff. Well, actually, the Pneumonia Severity Index is the product of doing a good study. When you think about how you would do a good study to look at what are all the things that would correlate with pneumonia, and then how, quote, sick they are with pneumonia. And you line up all these things. Age, if they're older, generally they're worse. Gender, men might be sicker. Nursing home residents, cancer, liver disease, congestive failure, stroke, chronic kidney disease, altered level of consciousness, elevated respiratory rate, low systolic pressure, temperature either too low or too high, heart rate up, bad blood gases, low sodiums, high BUNs, high glucoses, hematocrit less than 30, and an effusion on X-ray. So those are all the high-risk areas. They took thousands of patients and then added up all these point scores, did that retrospective cutoff that I talked to you about before, where they came up if you had X number of points, if you had either 0 points or up to less than 70, you were class 1, and then they prospectively validated that. That's the step that most of these retrospective data dredging looks don't do. They don't go and prospectively validate it. So they prospectively validated it. And so these are the things that you do. I think to do this manually, I've written down the stuff in here, what the points are, but you can go to the web and you get PSI and it comes on your PDA and you just punch in the right things and it comes up with the percent mortality and their class. And it gives numbers in between these cutoffs. So I gave you some examples here where you could have a 50-year-old male, non-nursing home resident, congestive failure, respiratory rate greater than 30, heart rate over 125, labs are normal, it's a class 3 with a score of 90 and a mortality of 0.9%. So you can actually calculate that. And so then how do you use that? I think what most of the people here say, with most of the articles, if they're class 1 or 2, they can go home. Class 3, maybe think about keeping them a little while, maybe some treatment in the ER, a little observation unit stuff if you do that. 4 and 5s probably ought to come in the hospital. And so then how good is that at doing it? And the first one looked at, it was a French study, and this is one of those association studies. They found that the ERs that used it had lower mortalities than the ERs that didn't use it. Anytime you look at a study, I think you need to always ask this question: is Group A equal to Group B but for the experimental variable? So are all the patients in these French ERs where they don't use it the same as the patients in the French ERs that do use it? And are all the doctors the same and all that kind of stuff? You can't imagine that they are. So is it really using the PSI that matters, or they just have better doctors, less sick patients? I don't know. But it was associated with a better outcome. Spanish study looked at PSI classes 1 and 2, and they either put them in the hospital or they sent them home. They did just as well at home, kind of thing. Canadian study here, the next one. They used it as a guideline. Admission and mortality rates were 2% and 0.7% among patients who were discharged according to the guideline, and 7 and 9% when they're discharged against guideline recommendations. And they used PSI as one of the guidelines. There's lots of guidelines for pneumonia, and that's just kind of one of them. So I think it looks like a useful test, and I think there's this mentioned over here. You can certainly use that for when you need to convince somebody that they need to come into the hospital. It's like, what is the BNP for? Oh my God, their BNP's 1,000. Oh, put them in. You know, whether that's true or not. 16 is just worth looking at just for some of these issues of studies. And it looked at what are the factors associated with mortality in the hospital. And as I mentioned in the write-up there, the only modifiable factors, because one of the factors was age. Well, we can't change that for the patient. So that's not a modifiable factor. But the only modifiable factors we're using in this study, Levaquin as the treatment, or levofloxacin as the treatment, and following a pathway, a guideline. So those are the only modifiable factors. But one of the things that had an increased mortality was getting an infectious disease consultation. So this is where of course, they're sicker people. They have a more complicated course. So it's not that infectious disease specialists are killing our pneumonia patients. So anyway, you understand association in that. Just remember that every time you see something, it says an association. How well do clinical pathways for community-acquired perform? That's actually, the studies here are pretty straightforward. They probably do better when they're on the community-acquired pneumonia pathway. Now, two issues there is, one, is it the pathway that really does it, or you're also attentive to all the other things about patient care because you're just doing other advanced things. It's just part of what you do that's well, and obviously the studies can't show that. I think the biggest thing with pathway issues is who goes on it. Like a lot of the ATLS stuff sounds real reasonable for doing that. It's just who should get it. You can't sprain your ankle and go on the ATLS pathway, or you have tubes and fingers in every orifice. I mean, that's silly at that level. This is the same way. Who should really go on that, and who should not? Should you take somebody off it if they have a tracheostomy in, or they've had chronic bronchiectasis? Can they go on the community-acquired pneumonia pathway? Which antibiotics work best? Those with bacteremic pneumonia did no worse. I've already covered that study. How soon can you stop IV antibiotics? They looked at that in here. Again, not so much an issue for ER docs as it is for in the hospital. Once they can take orally, you can probably switch them, even when they have bad germs running in there. Why? Because once you get the levels up, they kind of stay up. You don't really get higher levels with most of the IV stuff if they can absorb orally. Okay, how about emergence of antimicrobial resistant strep pneumoniae? This is one of the gotchas of immunization. We're going to look at it in some other settings here, but now that we have immunization against many of the pneumococcal strains, we don't see pneumonia with the 7-valent pneumococcal strain, that kind of stuff, very often. Okay? But doesn't mean pneumococcal pneumonia has gone away. It's just with strains that are outside of the immunization pattern or resistant to it. And when you get those, they tend to be resistant to common antibiotics. In this case, they looked at, I think it was in Massachusetts, and it was ceftriaxone. So they're not finding any more pneumococcal pneumonia than they did before. It's not like other serotypes have replaced the stuff we've killed off, although that is, that's a legitimate worry. There's, 22 subtypes of pneumococcal or more. So will they be replaced by other ones? And here they're not, but when they are replaced by it, they tend to be resistant. I don't know what we can do with that message. I mean, I don't think we stop using the empiric antibiotics that we did otherwise. Are steroids useful in treating community-acquired pneumonia? These are some funny papers here. For the most part, who would you think of putting on steroids when they have community-acquired pneumonia? COPDers. Exactly. So these aren't your ordinary people that you're thinking of putting on that. You're thinking they have some underlying component of COPD exacerbation. So I kind of discount most of these. There was some effect for putting them on hydrocortisone. These were people who went to the ICU and were real sick with it. The trouble that made it unbelievable in 27 here was this Italian study where if they put them on steroids, the mortality was 0%, and if they didn't, it was 38%. Exactly. That doesn't pass. I don't know what it is, but it doesn't work for me. How long do symptoms from pneumonia persist? This is good meat and potatoes ER stuff. The respiratory symptoms pretty much go away within about 2 weeks. By the time they're really over it clinically, the respiratory symptoms are gone. Feel lousy for a month, and that may not even come back to normal for 6 months. Just with doing that. That's sort of a kind of a gee whiz take-home kind of issue. And that's pretty much it. I know the key points and recommendations. I think we've pretty much covered all those. Any questions?